not do my training, did not go to pharmacy school here. I went to pharmacy school at the University of Kansas. So I'm a Jayhawk, and I came to Colorado for residency training. I've been in Colorado since that time. So I completed my PGY1 residency at the VA here. And then my second year of residency at this campus when it was in Denver, but University of Colorado. And I practice in geriatrics at the seniors clinic, as well as I teach in the school of pharmacy. A lot of my coursework is in the first year, but I also teach in the second and third years. And then I precept students at the hospital in the seniors clinic. I also teach in the medical school, the dental school, and I do research. So, CU is a major research institution. So all of our faculty are involved in research in different ways. My research is mainly related to drug safety. So some of my research is like a randomized controlled trial. Right now, I'm working on one where I do virtual drug regimen reviews for patients who have come to the emergency department with a fall. And I review their medications and everything for drugs that could be contributing to the fall. I also do database research. And I'm involved in a study right now where we are putting together some patient information about helping patients with dementia choose if they are really a good fit for some of the brand new intravenous agents that we have for mild cognitive impairment and mild dementia. So my job is awesome. I've never been bored. I feel really fortunate to be able to teach and do research and clinical practice at the same time. And every day is different. I never thought I would go into geriatrics. It was like not even on my radar whatsoever. So I think keeping an open mind is awesome. And I'm happy to answer any questions that you all have.
And actually, I have a question just right off the bat from what you said to get the ball rolling. So what was it that made you weren't thinking of, it wasn't on your radar to now you're in it all the way? How did you go that far?
Well, when I was a student, I kind of figured I really loved community pharmacy. I loved talking to patients and educating them about medications. But then I kind of figured that maybe I wanted to work in a hospital. So I did that as a student and I really liked it. But then when I was in my P4 year, I realized that I wanted to work in an ambulatory care setting. And that means that the patients are living at home or with family or in assisted living, and they're able to interact with you, and it's more longitudinal chronic care. And so I knew that if I wanted to do that, I needed to complete a residency. So I went to the VA for my first year of residency, and I chose the VA and matched there because it was a high amount of time in that year spent in ambulatory care. And during that first fall time frame of that residency, I was able to spend some time in geriatrics, and I had no appreciation really. I mean, I had grandparents and stuff, but I had no appreciation for just the complexities of care in older adults. It's very challenging and it's team-based because so many providers like social work, dental, physical therapy, physicians, nurses, pharmacists have to be involved to take care of older adults. And the older adults are just amazing people. They have great life stories. They need your help. And it just really was so rewarding to be able to work with those patients, and also the providers, the physicians and stuff, amazing people that work in geriatrics. So I really enjoyed the complexity of care, how rewarding it was. And so then my second year of residency, I spent way more time in geriatrics, and then it's a small field. So pharmacists can make a big difference. And a couple of years ago, I was elected the president of the American Geriatric Society, which is a physician organization, but they're interprofessional. And I was on the board of directors for quite some time, and then was a secretary of the organization, and was a second pharmacist to be a president of that geriatrics organization. They've had a few nurses as well, and then the rest have been physicians. So it's just, there's so many opportunities. There's job security because everyone's aging, and it's just an amazing field. But I was pretty naive as a student about it.
Thanks.
What other?
That is a common theme with I think this is our fourth Mile High meetup, and it seems to be that students come into pharmacy school not knowing where they're going to end up, and then their paths just kind of diverge later on, especially during the third or fourth year of pharmacy school. So that's great.
Yeah. And I think that's good that, we keep an open mind, and we have rotations that are in lots of, I did a pediatrics rotation, and I loved all my rotations. I did a rotation in nuclear pharmacy, and a lot of times we have students that will go like to FDA, and many of our students now I find are interested in industry, but even in industry, you could be working in an area that really predominantly serves older adults. So there is a lot of benefit to being, well-rounded in your training.
So any questions out there, feel free to, you can just say it on the camera or put it in the chat.
Are any of you from Colorado, or are most of you from other states?
I recognize a few names in here from previous meetings. I know some, seems like probably have a good mix
Okay.
in and out of state.
Yeah.
If you all don't have questions, I can keep asking questions.
Hi, my name's Katie. I'll ask a question.
Thanks.
Great.
And I'm from Massachusetts, but I did live in Colorado briefly, so excited to possibly come back. But I'm curious to hear about the most challenging parts of the job. I'd imagine it's not easy working with people who are nearing the end of their life, so just curious to hear about like the hardest parts of it.
That's a really great question, Katie. Of course, when we work with older adults, some of them do pass away, and it is always a difficult situation when you lose patients. The one thing that I personally have found is that oftentimes our patients are, they may be ready to go, or they may be, really just grateful that they have had such a great life and been able to have all of the experiences and their family with them. And so it's a little bit different than in the pediatric population when you lose a pediatric patient and, they're an infant or 3 or 4 years old, younger. It's just, it's a little different way that the patients are handling it. But in our clinic, we have patients who are sometimes on hospice, and they may have palliative care in the hospital as well. And we have pharmacists that work in hospice. I don't work in hospice, but I may see the patient if they come in for a visit, even though they are enrolled in hospice. And, one of the things that I think as a geriatric pharmacist that is really rewarding is being able to help provide comfort for those patients and be able to help them meet their goals of care. So goals of care are a, like basic conversation we have with every patient. The patient could be 65, they could be 102. We've had patients like up to 110. And their goals of care could be very different. So some patients, could be 65, but very ill, and their goals of care may not include things like chronic medical conditions, treating those chronic medical conditions, or like they may not want preventive care with immunizations or statins, which we use to prevent heart attacks and strokes. And then there could be like a 90-year-old who estimated life expectancy could be another 10 years, and that person might be very interested in preventive care. And so we have to ask all of our patients what their goals of care are, and we really want to have those conversations so that we can be helping them choose treatments that are in line with their goals. And sometimes it's their caregiver goals as well. So one of the challenging things besides just death in the patient population is that people are over medicated. And so as a pharmacist, like, I'm not always trying to get people on medications. I'm trying to stop medications, and I'm trying to help the patients be on the ones that are best for them. So oftentimes, you know, I mean, like, for example, I saw a patient and she was on 50 drugs, and we didn't want her to be on 50 drugs. She brought all of them in a tackle box, like a massive fishing tackle box. And that took me several hours to be able to go through all of those medications with her and, you know, start to try to trim them down. And I was only able to, on that first visit, stop 5 of the 50, so like 10%. And then we had to have more visits to try to pare it down, because you can't always like stop cold turkey. You may have to taper the drug over months. And so it is really challenging, also just the over medication of people in the United States. Fun sometimes and challenging.
That's really interesting. Thank you.
Thank you for asking the question, Katie. What other questions do you guys have? Doesn't have to be about geriatrics, or it could be about whatever.
I guess I can, oh, sorry, Sam, you go ahead.
No, you go. Yeah, you can go ahead. You can go ahead.
I was curious to hear about your research as well. I studied neuroscience in undergrad, so I know a little bit about Alzheimer's and like dementia, and I'd just be curious to hear about, I guess, how you know when a patient might be a good candidate for novel agents and how that works.
Yeah, so the study that I'm working on right now is developing a decision aid or decision tool to help clinicians and provide clinicians and patients and family members work through some of the logistics, and also work through some of the pros and cons of initiating the new monoclonal antibodies, which are FDA approved now. We have 2 for mild cognitive impairment and mild Alzheimer's disease. And these agents, when you think about drugs, there's always a risk and a benefit, but oftentimes, obviously, the benefit outweighs the risks of the drugs. And in geriatrics, that's like 101. We're every day weighing risks and benefits of drugs, because the risks are so much higher in older patients. Also in, infants, the risks could be very high too. And so weighing the risks and benefits, when you have new agents, sometimes you don't have enough evidence. And so this decision tool is really geared towards providing and like breaking down the complex medical terminology of a lot of these risks and benefits. The new monoclonal antibodies are very expensive, so cost is included in there. And then side effect wise, like, they do have some basic common side effects, like they cause headache or dizziness, but they also have very severe side effects, which include bleeding or hemorrhage in the brain, and also edema in the brain. And therefore, these require MRIs of the brain regularly prior to certain infusions. So when we give these agents, they have to have baseline MRI, they have to have a baseline PET scan or a CSF testing, cerebral spinal fluid testing, to identify that they have the amyloid present in their brain or CSF. And these are anti-amyloid antibodies. So the medications help clear the amyloid from the brain. And this is really one of the main thoughts of how Alzheimer's has developed. But honestly, they don't cure the patients. And so we know there are other pathways of the pathophysiology. But in this case, these medications have really severe side effects, have caused death to the patients. And so when you think about the context of these patients with mild cognitive impairment, they're functioning still. They're at home, they're living their regular life. They may have some impairments in memory, but they're still functioning. Some of them are probably working. And so then you consider the severity of the side effects, the edema or hemorrhage in the brain, possibly death. Sometimes they're asymptomatic. And so the severity of the side effects is so great that you have to be thinking about the benefit. And Alzheimer's disease does have a genetic component. And so we have to do genetic testing as well in order to determine, because those they're called ARIA, amyloid related imaging abnormalities. Those side effects are more predominant in a certain genotypes. And so we have to do genetic testing. And then that, unfortunately, that genetic testing also can indicate that their family members, if they have children or grandchildren, might also have that genetic makeup as well. And so then, I mean, it's like very complex, and it takes a lot to be able to diagnose that with the patients have amyloid present, and make sure that that's their pathophysiology. And then giving the medications is high burden, high cost, high risk. And also the genetic testing has to be done because the FDA has a black box warning now that describes these ARIA side effects being higher if the patient is, it's the apolipoprotein E. And if they're the E4 allele homozygotes, then they're higher risk for that side effect. So yeah, it's super interesting. I mean, one of the things that's great about going to pharmacy school and just working with drugs in general is like it's an explosion of drugs, of a lot of drugs. And it's really hard for other healthcare providers to keep up. So a lot of the time, like I'm on the study for drug education purposes. The physician that runs the study, geriatrician, I mean, of course he knows these things too, but like I'm on the study for my drug knowledge. Did that answer your question? In a long-winded format?
Yeah, definitely.
One of the things that I think is good is that there are a lot of areas to work in pharmacy. So, you know, I didn't know, I thought maybe I'd work in a community pharmacy. And that is one of the pathways that a lot of our students take, is to work in the community. So you can work in like a chain pharmacy or a retail type situation, or sometimes community pharmacies are independent. And then when you think about outside of the community, there are positions in the hospital on the inpatient side. There's also positions in the outpatient side. So other clinical pharmacists like myself work in clinics, and they are maybe not faculty. And then you also have nursing home pharmacists, and the nursing home is by law required to have pharmacists review drug regimen reviews in the nursing home. So that's
what? I had 2 eggs. Me too.
me too, Brooklyn. Anyway, there are a lot of different areas, hospitals, nursing homes, assisted living, sometimes hire pharmacists to do reviews. And then you think about industry, and there are a lot of different positions within industry. Many of our students go into industry straight out of school now instead of doing a fellowship, but you can also complete a fellowship. And then we think about, you know, pharmacists maybe in consulting roles, educational roles. So there are a lot of places that you can work as a pharmacist. So Ashley asked a question. How do you see, or have you seen, advancements in technology like AI and automation, for example, affect job opportunities for pharmacists now and in the future? That is an awesome question, Ashley. If I had all the answers to that, I'd probably be making a lot of money. But I do think there are a lot of benefits to automation and AI. And just over the course of my career, I've seen the ability to move the pharmacist more into that cognitive role where they are patient counseling or verifying things instead of actually counting pills and filling medication, where a machine can do that. So that, has been occurring for a while, which is great because the actual physical process of dispensing medication is, oftentimes not, we don't need a pharmacist to do that. So that's happened. But like in our curriculum, I teach in the first year, and the course that I teach is called self-care and non-prescription drugs. And so we teach the students how to handle non-prescription drugs, how to triage patients appropriately to either going to a provider or taking an over-the-counter medication, which over-the-counter medications are safe and effective for certain patients, because even though they're over-the-counter, it doesn't mean they're safe. And so we have used ChatGPT, and we used another tool off of Microsoft that we had students go and look in our drug information resources that are reputable, that we teach them how to use. For example, they would have patient cases and they would use AI. They would type that patient case or copy and paste it into the AI field, and then see what AI says about it. So for example, maybe the patient comes in with osteoarthritis pain, and they have a history of high blood pressure, and their knees hurt, and the pain score is 3 out of 10 or whatever. And they're on these certain medications. What could they take over the counter for their pain? And so ChatGPT will give you an answer. And then we have a different AI program would give a different answer. And then we have the students look up the information in our drug resources and kind of compare. And so that activity is really geared towards understanding that AI does have a lot of information, and it's often accurate. It can also be inaccurate, and how to really kind of differentiate the accuracy, because patients are using those tools as well. And even like Google, you can just go into Google now and get an AI summary. I also was talking to someone yesterday who said that Snapchat has AI, which I did not know. And I'm kind of curious what Snapchat's AI is like, but I think it's really important to be able to be familiar with those tools, because patients will use them and they can be really helpful as well for clinicians. So I think it will not take away the job of a human, at least not right now. But I do think if it makes our job easier, I'm all about that. Do you guys know about Snapchat AI? Like, has anyone used it? I would love to hear if you have, because I'm very curious about it. I don't have Snapchat.
Yeah, I've used Snapchat AI before. It was just like learning other languages.
Okay, does it answer questions for you like ChatGPT might?
Yeah, not to like the same level as ChatGPT, but it does answer questions pretty well. And it answers questions as if you're in a conversation with another person.
And that's how AI does too. I mean, like ChatGPT does. Because like sometimes I'll type in a question to ChatGPT and it'll say like, was that good? And I'll be like, no, that answer was not good. And I'll say like, you need to blah, blah, blah. And it's like a conversation, and it responds to me when I do that. So yesterday I was talking to someone who was giving a presentation, and they said they used Snapchat AI to like sometimes, but they didn't use it for the presentation. And the person said they'd used some more technical words, scientific words that they didn't really understand very well. And I said, well, you can go into ChatGPT and ask ChatGPT to explain it at a lower level. Like maybe you ask 5th grade reading level or 8th grade reading level, and it will tell you how to explain it to other people, which I think is helpful for students that maybe want to give patient education. But so Sam, would Snapchat be able to do that too, do you think?
I haven't tested it yet, but since it's AI, it most likely could.
Yeah, okay, that's interesting. What was your other question, Sam?
My other question was kind of leaning towards school, and I was gonna ask about what was your experience during your years in school for pharmacy, and what was the hardest part about it? Was it the clinicals, the lectures, or you can also talk about what was your hardest semester and what you did to kind of level yourself up to go beat or to defeat those problems that you face.
Sure, that's a great question. Um, I mean, things have changed a little bit in the way that we teach. I think many of my courses were lecture-based courses, and now we have a lot more hands-on type courses where you're doing activities, which I think most of the time will really reinforce that material so much better if you're using the information you're learning it to work on a patient case, for example, or to actually practice. We have standardized patients. I didn't have that opportunity as a student, but we have standardized patients where it's an actor playing a role and you will educate them or interview them about different things. And I think that really enhances the learning when you're applying it. One of the things that I think sometimes is, I mean, the first semester of pharmacy school is always tough for people because they're coming from different backgrounds and levels of understanding. Perhaps some were technicians, some were not technicians. Some students, you know, are coming from out of state to Colorado and they're just navigating the area. And so I think it's really tough. The first semester is tough for everyone. Also, sometimes people took less course loads, you know, in undergrad. And I went straight into pharmacy school, so I did not get a bachelor's degree. I think you don't have to get a bachelor's degree to go to pharmacy school. And so I think sometimes when people are maybe taking time off too, they get out of that study mode. And so like if you go straight through, maybe you're still in the study mode, but other people might not be, and they have to get back into that. And that takes a little bit of time too. But one of the most important things that I think is, well, okay, I got two really important things. One of the most important things to be successful in pharmacy school, no matter where you're at, is to not wait too long to ask for help. So, for example, if you are in pharmacy school and, you know, the course load is high and you're struggling at CU, we provide tutors to anyone. So the tutors are not for people that are trying not to get a D. The tutors are for anyone. So like, let's say you start to take some exams and you're adjusting and you maybe got a B on an exam and you want an A, your goals are to get a 4.0 or something. You should work with the tutors too, because really reaching out and asking for help is not any way a weakness. Reaching out and asking for help from your professors or from Office of Student Services, from the tutors, is a strength, because we're teaching one way and people learn differently. And so sometimes the way that we're teaching doesn't match up perfectly with a student's way of learning. And so maybe that has to be adjusted, or the student sometimes we have language barriers. And so maybe the student needs some assistance with language. And sometimes we have students that just need to study with another person. And so we help them find study groups. And so I really, really encourage all students, no matter where you're at, to ask for help before you run into trouble. And luckily, in the last year, we started providing, well, maybe 2 years, we've been providing tutors for free. And so the tutors are students who already took the course. So they maybe are P2s or P3s. They're awesome students. They work with the faculty for each course, and they really try to tailor that learning to the students. So we have one-on-one tutors. We have group learning, large group and small group. So like, maybe I'd say like at least a third or 2/3 of the class will go to those large group tutoring sessions. And it's not just about grades, it's really about like making sure that you understand the material, because you're like, you know, you have a lot of responsibility as a pharmacist. You can harm people. So you got to know your stuff. And so asking for help, not really even asking, but just utilizing the tools that you can use, and then asking for help if you need it is really important. Also, Sam, another thing that I would recommend is just studying with other people. And because if you can explain the material to your friend or classmate, then you have to know it at a deeper level. And so oftentimes we see the students who struggle the most are those that don't study with other people. And you don't have to do all your studying with them, but like you could study on your own and then get together as a small group or a larger group, whatever you want, to sort of rehash the material. That is so effective. And verbalizing it often helps people. Writing it on whiteboards helps people, or writing it down. Just like figuring out your learning style is important, and then making sure that you have the resources that you need to be successful. We are huge on that here. Not every school is like that. I mean, I would say we have really focused on that over the years at providing those resources for free. Am I telling you stuff, Noah, that you already knew?
Me?
Yeah.
Yeah, I know most of that, but I didn't. I think it's very useful to hear, and very good for everyone to hear, regardless of, you know, if you all end up at CU, fantastic. But even if you end up at other schools, we all want you to be successful, and that's just great advice, especially the studying part. It's bringing me back to my my college days. And I'm curious, what if someone hears you speaking and thinks, wow, geriatrics is a great, it seems like a great area to be in professionally or academically. What are some steps do you think that they could take to get to where you are?
Well, I think, again, keep your mind open so that you know that you have opportunities in different areas and you can explore those. Typically what I see is, like, as a P1, those P1 students may ask faculty to shadow them. So for example, like if you were thinking geriatrics was something you might be interested in, we have 3 geriatric pharmacists that on faculty here, myself and 2 others, and you could come shadow and kind of see what we do for an afternoon, just so you have a better idea of, you know, what kind of setting it is, what kind of patient population, what are the activities, and then you can shadow multiple different pharmacists and kind of see what they're up to. Also, so I think reaching out and like having that exposure is really helpful. And then if you want to pursue a specialty, you really have to consider residency training. So residency training, typically that first year is a more general residency that's well-rounded. And then the second year is a specialty where, for example, there's tons of options, but you might see an ambulatory care focused residency. You might see an ICU or critical care focused residency, oncology focused residency. Also geriatrics, obviously, pediatric focused residency. Sometimes there's long-term care focused residencies or managed care focused. So they might be in a certain patient population, like palliative care PGY2 residency, where you're really focused on one type of patient population. Or it could be the setting, like ICU versus ambulatory. Infectious disease residency is another one where it's like all ID. And if you want to go into a specialty area, you pretty much have to do at least 1 year residency, but often 2 years of residency after pharmacy school. Now you get paid during those years of residency. And there, I mean, like when I was a resident, I got paid barely anything but above poverty level. But now it's pretty decent. Like I think most residents make like $60,000 $1,000 a year, which helps you. You can also defer your student loans, so that helps too. But it's not like you're paying to do it. You're getting paid. Yeah. It looks like Tenny had a question. So, Penny, you said you are a mature student, and it sounds like maybe this is a second career for you, and you'll be needing to take the prereqs for this. For sure, we have older students in our curriculum. I would say the average age is probably like 30. And then we have, some younger students. I think this last fall, I had someone who wasn't 21 yet. So they were really young. And but I think we only had one. And then we definitely have students who are more mature and have families. And so when we think about the students who have families, you may be like those kind of students, maybe students who need to be thinking about our resources that we provide and ways to, be perhaps in the remote program. If you're living in Wyoming and you don't want to move to Colorado, you can be in the remote program. Apply for that. And it's important when you apply for the remote program to be thinking about like, how am I going to approach this school? How am I going to approach the curriculum? What are my ways that I'm going to have time management in terms of being able to take care of my family and also go to school? And, we have had many students who are successful in those areas. And so our Office of Student Services has a lot of knowledge and expertise in helping students be successful. So we definitely have students who come from all different areas. We had a student in our fall semester this year she was in the military and she's still in the reserves, and she has 3 kids. And I mean, like, she came to class every day. She had great stories. She used her information right away with her kids and like the drug stuff that we were teaching, and was super active and did great. And then we had a person who had a baby and brought her baby to class, and like tiny little baby, like tiny, like 5 pounds. And that baby went to the whole rest of the semester with us. And so, we didn't cry, it didn't disrupt class, and, we work with you. So it's definitely possible to be able to, come back and go to pharmacy school. And let's see, hoping to also work. So working during school, I think, is great, but I think you have to be careful about how many hours you're working so that you can balance, your life and your schoolwork. I think a lot of people from Colorado Springs are in the remote program. And Ashley, I love that you have a BS in sports management, MBA. That will help you too. Like, for example, one of our big sections of the first course that I teach, self-care, is musculoskeletal stuff. And a lot of students struggle with that because they may not know all of the musculoskeletal kind of things. And you're like, you'll probably be way ahead on that. So I think, you'll be able to use those skills in pharmacy school for sure. And MBA is very complementary. Sometimes we have students do a PharmD MBA at the same time.
Very good input. Thanks.
The remote program is the same as the on-campus. So the only difference is you still have to come to campus a few weeks of the year, but you will be on Zoom, and it's synchronous, which means that you're in class on Zoom at the same time, preferably. So instead of being sitting in the room with us, you're watching me on Zoom. Some people learn fine that way. Other people, like, I had a student who was ordering a salad one day while I was teaching, and she unmuted, and so she was ordering the salad, and I was like, hey, blah blah blah, I want a salad too, So sometimes there's little things that happen like that, but we try to keep the remote students really engaged as well. is the remote program for those outside. You can be in Colorado or outside of Colorado and apply to the remote program. Yep. So there is like a minimum miles that you have to live from campus. I think it's like 20 miles, something like that. Don't quote me, but something like that.
I think it's a little more. I think
Is
it's
it
40 maybe?
40
Yeah,
miles? Okay.
it's something like Longmont to the north. And it gets most of like, if you're in the Denver metro area, you cannot do the remote, but outside of that, you're good. You can do the remote. Unless if you're in a different country, you can't, but within the boundaries of the US.
Yeah. I mean, I would say we have multiple remote students from Colorado Springs. Sometimes they will come in person more than because you can come in person. We want you to come in person if you can. But then like in the winter months, they're in the remote program, so they don't have to come in person. Winter months, it gets hectic.
Okay. Oh. Looks like we'll have this as the last question. So we have this scheduled to end a few minutes ago, but if you don't mind, take this one more question and then we'll wrap it up.
Sure. So Katie's curious to hear about how much of my clinical work involves speaking with patients directly versus collaborating with physicians and other healthcare professionals. So in our clinic and in Colorado, we have collaborative practice agreements, which allow us to, if the providers have signed off on it, we can manage the medical conditions independently. So we have those collaborative practice agreements for hypertension or high blood pressure, high cholesterol, diabetes, other cardiovascular risk, osteoporosis. We also do annual wellness visits and bill for those. So those are all independent. So we'll just talk to the patients. We gather the information. What's their blood pressure? What's their blood glucose? How are they doing after they fractured their hip? And we just start adjust the drug, send prescriptions. The prescriptions are all sent to the pharmacy under the physician's name, whoever their PCP is. But we are the ones managing that, and we just send our notes to the providers to read over. But we've already implemented the plan, and so that's legal in Colorado and many other states. For annual wellness visits, we will do the exact same thing as a physician, and we will bill for that through Medicare. And so I'll adjust the medication list. I'll order a bone scan for osteoporosis screening. I'll order a consult podiatry if they need their feet checked. I'll order an eye clinic referral. So I can do all of that. Again, I order it under the PCP's name. My name is listed there as the ordering person, but we have more privileges than the nurses do. And so we're like really working at the top of our scope. That's probably, I would say, at least a half to 2/3 of what we're doing. The other third would be collaborating with providers for questions they have, or like going in and seeing a patient, or like if they have COVID, we have to do a mandatory drug interaction screen to see if they can get Paxlovid because it has so many drug interactions. So we do that. So like it'll come to us first. We'll write a note on their COVID stuff and their drug interaction screen and then send it back to the provider. Do you have to come to Colorado and live for a year to be considered in-state? Yes. You have to, and you have to get a driver's license and some other stuff in order to be in-state. There are some rules about that.
Yeah, if you're planning to be an on-campus student, that first year you're going to be out-of-state tuition, but then the second year and so on, you should be able to qualify if you meet some things as in-state tuition.
And Sam had a quick question about, can you complete clinicals in an area you work in as a pharmacy tech? Yes. There are minimum requirements though for the 4th year of pharmacy school. And so like you have to go into community pharmacy, even if you work there, you still have to do it. Usually we try to set you up in a place you haven't been, so you learn something new. You all have to do a health system rotation where you learn about hospital pharmacy. So like there's minimum requirements. And even if you worked in those areas, you have to do it. Can't test out or anything like that. those are national accreditation standards. They're not like set by Colorado. You guys are awesome. Thank you so much for all the questions. I mean, I could sit here for hours, Noah.
Gotta cut it off at some point. Well, thank you so much for taking the time and meeting with our prospective students. I really, and I appreciate all of you for attending. Am I cutting out? Anyway, I said my connection's unstable, but okay. Thank you all for attending. Thank you for joining us. If you have any questions, you all have my email address, so please let me know. And like I said, if you want that application fee waiver, email me and we can make that happen. Yeah, thank you again for attending, and bye, everybody.
Thank you guys. Good luck.